Amy, actually, I know you reached out to me asking me about some of the things that we'll cover today. I think I didn't get back to you because COVID hit and here we are. So this may answer some of those questions. So I was asked to talk about insurance today because my doctors come to me every single day asking the same questions over and over again. They should be in here listening. But I was just going to go through a few of the basics to teach your patients how to understand their insurance because it's so complicated and it's confusing, and this doesn't cover everything, but it at least go over the basics to get them started to know what questions to ask. So you can go to the next stage or the next screen. So this is just a useful graph that I found helpful to make patients understand when they call in and say, hey, you know, my medications are too expensive. You know, they think it's going to be $500 a month every single month, whereas it may just be their deductible. So the part one of your insurance is your deductible. Sometimes it can range from $100 all the way up to $5,000, and this is the portion you pay before your insurance picks up anything. So the second portion, you either have a co-insurance, which is a percentage. Oftentimes we have 70-30, 80-20, 90-10. The insurance plan picks up 90%, you're responsible for 10%. Or you can have co-payments. They are set amounts, say $100 for an emergency room visit or $25 for an office visit. You can also have a combination of both in your plan. Part three is once you meet your maximum out-of-pocket, this is when the insurance will pick up the rest. So sometimes this could be like $5,000 or $10,000 if you've paid out that much money with your deductible and your co-insurance, your co-payments. Then you hit this maximum out of pocket and the insurance does pick up the rest, also called catastrophe. So this is a nice little graph that I just want to print out and hand to my patients so that they understand a little bit of why they're paying what they're paying. So next. This is understanding Medicare. So with Medicare, there are letters of the alphabet. Part A covers your hospital. Part B covers your durable medical equipment, your doctor's visits, and preventative services. And then they have, so these are the two parts that come out of your Social Security check, $135 a month, pays for those two parts. But then you have to pick up a Part D. So this is your prescription drug coverage. This can be as cheap as possible, that can cover just generic drugs, or it can be a decent plan that will cover everything, everywhere in the middle also. So a lot of times they come and they say, you know, my patient has Medicare A and B. What medication can they get covered? So I always tell them I need to know what their Part D is. Or there's a Part C, and this is a Advantage plan, which takes over Part A and B and adds D together, and it's just one plan. You'll often see these called like Humana, Aetna, Cigna. These plans can be helpful because Medicare is very black and white. They either cover it or they don't. When you have a managed plan, you can sometimes call and ask, you know, for exceptions, plead your case, ask for a peer-to-peer, and sometimes get things that are covered, will be covered, that aren't typically covered by Medicare. So next. So understanding Part D stages in the donut hole. A lot of patients come in and say, you know, I can't afford my medicine. They all of a sudden became $500 when last month they were $40. So that's when I suspect they've hit the coverage gap. So I had a drug rep explain this to me, but I find this picture super helpful. So once again, first we have your deductible. It can be anywhere from $0 all the way up to about $400 with Medicare plans. And they have to pay that out. So January 1st, the first prescription they pick up may be pricey. The second stage is the initial coverage. So once again, you either have copays or percentages of the medication, all the way up until the whole cost of medications, what your insurance has paid and what you have paid, is at $4,000. Then you enter what's called the coverage gap or the donut hole. So here, patients pay 25% of the cost of the brand name medications. So this is important for diabetes because most of our medications are brand name. So the idea is for the patient to pay their way out of the coverage gap. With my patients, that's not plausible. They, you know, don't have $2,000 laying around, you know, to cover these medications. It often hits somewhere between April and August, sometimes all the way up until December, depending on when they started the medication. So once $6,300 is paid out by the insurance and yourself, when it meets that line, After that, you pay 5% of your cost. It's called catastrophe, and you'll have very small, or it's covered at 100%. Like I said, many patients never get to that because they can't afford their insulins through the coverage gap. So next. So here I've just chose a few of the insulins that we're familiar with: Humalog, Novolog, and Lantus. And one box of Humalog or Novolog are about $500 plus. Lantus a little cheaper on $400, so that gets you 5 pens. So say we have a patient who's on 75 units of Lantus, 30 units with sliding scale with each meal. So 75 units per day is 2 boxes for a 30-day supply. 90 units per day is also 2 boxes for a 30-day supply. So that's roughly $2,000 for a 1-month supply of insulin. So when a patient comes to you and said, you know, my insulin's $200 a month, I need them to look at how much the insurance picked up. They picked up $1,800, you're left with the other $200. So it may, when people hear my insurance covers it, they often think free, and that's not the case. So West Virginia recently capped the price of insulin to $100 per prescription for commercially insurance patients only. This is not cash or Medicare, Medicaid, things like that. So that doesn't even go into effect until at least January 1st. Medicare also just recently capped $35 per prescription per month. Once again, that's not until January, maybe even after. So next slide. A few ways that your patients can get assistance. The first one is called low income subsidy. This is something that they can apply for through the Social Security office. They may qualify for full or partial assistance that helps in their copays and their premiums that they pay for their Part D. So this is, unfortunately, the Social Security office lately is very hard to get a hold of. If they're open, it's only by appointment. Their telephone calls are, you know, probably hours wait, but it can help them if they qualify. This is also kind of rolls into Medicaid also. If they qualify for full assistance, that virtually puts them on Medicaid. So the next option is patient assistance. So this is available through the companies. They each have their own rules, regulations, but it's typically for someone who has no insurance, or they have Medicare, or if your insurance plan doesn't cover their drug. So say an insurance plan likes you to have Novolog, but Novolog doesn't work for you. So we, you know, they want Humalog, so we can ask the insurance company, sorry, I saw a message at the bottom of the screen. We can ask the drug companies, you know, will you cover this? And sometimes they will give them the whole year free just because their insurance doesn't cover the medication. So on the left-hand side, I've put a little table that shows what 400% of the national poverty level is, because a lot of patients hear patient assistance and they think, I make too much, I don't qualify. So for a couple who's on Social Security, they can make up to $68,000 and still qualify for patient assistance. So that actually hits a lot more of my patients than they believe. And before COVID, you had to pay out $1,000 to $1,100 on prescription medications before patient assistance would kick in, but because of COVID, that has been waived. And I've also heard lately that the percentage of federal poverty level has been waived also. So if you apply for medications and apply for help, they'll virtually give it to you. They also have a COVID-19 job loss exception. You just have to prove that you have either lost your job or lost your benefits due to COVID. They don't require proof of income or anything like that. So the insurance companies have at least stepped up during coronavirus to make sure patients don't go without their insulins. Next screen. And yes, low income subsidy is also called extra help. So coupons and savings card, there's a few out there that are hard to find. The savings card for commercial patients you'll often get from your drug reps. You can find them online at the websites. They're available for almost every insulin out there. There are a few extras that if you kind of search hard, you'll be able to find them, or call the companies themselves. They'll offer these to you. Sanofi has one called a 99 value savings card. It's for uninsured patients only, and they can pay $99 for up to 10 vials or 10 packs of pens. So that is an immense amount of insulin for $100. Novo Nordisk also has My 99 insulin, and all patients qualify, even Medicare. I had one that went through yesterday. And they get a 30-day supply of any combination of Novo Nordisk and insulin products. And I think that covers up to 3 vials or 2 packs of pens. They can do a combination of 3 vials and 2 packs of pens, or any combination of that for $99 for 12 months. Lilly Care has recently had one that's called the Lilly's Care Solution. It's for uninsured and commercial insurance, and they can fill their monthly prescriptions for $35 for any of the Lilly products. So Basaglar, Apidra, those medications for $35 a month. And also, if you call the Lilly Care Solution, they claim that they will not let anybody go without insulin. So, you know, if you are struggling, just can't afford your medications this month, you may have lost your job, you may, you know, have other issues coming up, they claim that they will not let anyone go without. So just calling the Lilly Care Solution hotline, they will figure out something for you. Next screen. So CGMs. With diabetes, CGMs is becoming the norm. Everybody is on a Freestyle Libre because it is so affordable, or Dexcom. So a few hiccups that, you know, I get when patients come new to us is, my doctor's been trying to get this for me, but it's not covered. So this has been a little bit of a challenge to figure out what's covered where. So I'm gonna start with Medicare. So if a patient has straight Medicare, A and B, these cannot go to a local pharmacy. They must be covered at a durable medical equipment company. So you send it to the pharmacy, they're gonna come back, it's $160 a month. You know, no one wants to afford that. So they say it's not covered, but it's just not sent to the right place. Walgreens, however, can process Dexcom. They're the only pharmacy that can do this. They have a contract with Dexcom. Advantage plans, such as Humana, have particular durable medical equipment companies that they work with. They don't advertise this very well, so you can send them to another company and it'll be really expensive, but they'll process it. But if you go to their preferred of CCS Medical, it's often a lot cheaper. For West Virginia Medicaid, they cover it at a pharmacy with strict requirements. You have to have 90 days of blood sugars 4 times a day and show proof on a prior authorization. Also, you have to be compliant with picking up your medications for the last 6 months. So unfortunately, sometimes I do have patients who have to wait 6 months to get a Freestyle Libre or a Dexcom because they just haven't been picking up their medications. For Maryland, Medicaid, it's covered with prior auth through Express Scripts. And for PA Medicaid, it's covered through medical benefits. So you have to send it to a durable medical equipment company. For commercial insurances, the CGMs are often covered at the local pharmacy. In the beginning, they told us, you know, all of them are covered without a prior auth. So what I found is every time I get a prior authorization back on an insurance or a commercial at a local pharmacy, it comes back denied. So I don't even prior authorization do any of those for commercial patients. I simply send them to a medical supply company because the problem is they don't have coverage through pharmacy benefits. They have it through their medical benefits. And the 3 I use the most and I found most helpful is EdgePark, CCS Medical, and Adapt Health. Next screen. Another thing I found super helpful on an iPhone, it's called Coverage Search. It's this app up on the top left-hand corner, and it looks like 2 little pills crossed. So if you download this app, you're gonna find on the right-hand side, you can choose your medication, what state, and for what type of insurance. So here I've screenshotted Basaglar for West Virginia Medicare. So we see that we have CVS Caremark, which is now Aetna, Blue Cross Blue Shield, Highmark, OptumRx, our health plan, Humana. It'll show you what medications are covered, kind of prevent that guessing game that we play at the pharmacy. You know, well, let's try Basaglar, it doesn't go through. Let's try Lantus, it doesn't go through. So this app is usually pretty accurate if you can find the health plan that the patient has. Sometimes our patients have these teeny tiny little Blue Cross Blue Shield plans that have picked particularly what they want to cover, and those are hard to find, so we still have to play that game at the pharmacy. But this website, or this app, I pull up on my phone 100 times a day, so I found it super helpful. Next screen. So any questions that I may be able to help you with today?
Thank you so much, Sheree. That was excellent. So before we jump into questions, I saw we had a few more people hop onto the call during that presentation. So I just wanted to give them a chance to introduce themselves as well. Jen Lucas, did you want to introduce yourself?
Sure, I'd be happy to. Thanks. I'm Jen Lucas. I am a coordinator with the West Virginia Practice-Based Research Network under Stacy Wanger.
Awesome, thank you. And Stacy?
Hi, I'm Stacy Wanger. I'm the Assistant Director for the West Virginia Practice-Based Research Network.
Awesome, thank you. And Nate Foran? You may be muted. All right, no worries. And Andrea? Oh, we got a chat in from Andrea. No microphone on desktop, no worries at all, but she is a disease management coordinator with Population Health Group, I believe with Donna, actually. So thanks for joining, guys. All right, so let's open it up for questions. Any questions for Cherie and that didactic on understanding insurance?
I just want to say I think this is going to be very helpful, and I appreciate all the time that you put into putting that together. So when we get the PowerPoint, I think Amy's with our group too. We're all going to be printing it out and sharing it with our colleagues. Thank you so much.
Thank you, Donna. So there's a question asking, are there any recommendations for patients who ask about their emergency room visits?
Typically, those can be listed on your insurance card. It'll tell you what your copay is. But if you just call your insurance, there's member services on the back of the card. You can get to someone that they'll usually be able to answer your question. And I know it's frustrating to pick up the phone and call them because sometimes you sit on hold, but sometimes that's just what I got to do to figure anything out. Just start from scratch and start asking questions.
Thank you. Any other questions? Got another chat in asking if there's a convenient way for patients to see which providers are in their network along the lines of the apps that you showed with the screenshots to find drug coverage.
So I don't know of any apps, but if you do go to their websites, you can often put in the first 3 digits of their insurance ID number and it will show networks. I know with Blue Cross Blue Shield, ours last year was up to 6 months delayed before they had that out there for us. But you can call and ask. If you call them, they'll give you a provider. You can tell them, what type of provider you're looking for and what zip code you're looking for. And they will be able to tell you whether it's in network or out of network. One thing I did find with our insurance in particular, Cardinal Pediatrics. I have kids. I lived in Bridgeport. I didn't want to drive to Morgantown when my kids were sick. So Cardinal Pediatrics is in network, but they're not preferred. So we had 3 levels. We had preferred in network, and out of network. And the middle one, in network, had its own deductible of $6,000. So unfortunately, I had to switch pediatric doctors because they weren't preferred in network. So they don't really express that to you until you get the bill and call and start asking about it. So that's something I found that you got to ask, is there a preferred? And that goes the same for durable medical equipment companies, pharmacies. Here at WVU, we have preferred pharmacies of our local POC pharmacy. There's also one at UHC that works just like the POC pharmacy. And those are preferred. A medication like Saxenda, I know Dr. Davison uses that, and it at CVS is $600, but if you get it at our local pharmacy under our insurance, it's $60. So that information isn't really known out there. It's just trial and error and start asking questions. So there's also a coupon for that one that brings it down to $25. So you ask, not only is it a network, but now you also have to ask, is it preferred? Another thing with Humana, I found that I've called asking those exact questions. Do you have preferred in-network pharmacies? And they'll tell you, yes, our Humana pharmacy. However, insulin is $200 there, whereas at Walmart it's $150. And their preferred in-network pharmacy is more expensive. So it's not always the right answer. That's why insurance is so complicated.
Absolutely, thank you so much. Are there any other questions, comments, thoughts? Feel free to use the chat feature as well. We may get more questions in a little bit, but in the meantime, I wanted to sort of give the floor to Dr. Davison too. We are part of a metabolic group, and she's very interactive in that and everything. So, Dr. Davison, I didn't know if you wanted to maybe give a little intro. I know in our last meeting we sort of talked about the endocrine group as well. So.
Sure. So just, I guess, just to let everyone know what we have going on. So we are doing, medical weight management programs. So what we're trying to do in our clinic is basically use a team-based approach to really providing patients with the tools and the support they need to have successful long-term weight loss, with a basis of, lifestyle changes, but using all the tools in our toolbox to help them with anything that can help them adhere to those lifestyle changes. So we use, individual visits where we kind of look at 4 parts. We look at their food, their movement. We look at behavior change strategies that have been proven to help people stick with long-term changes. And then we look at their medical piece. So we try to optimize their chronic medications. And so a lot of care for diabetes overlaps with that, because there's a lot of new things that can be done with treating diabetes that can affect people's weight, either in a positive or a negative way. And so we try to optimize things there. And we're trying to make sure that our patients get the support that they need. So one of the goals that we have is making sure that all of our patients get seen every month. Telemedicine has been fantastic for helping us do better with that. So we're really excited that that's one good thing that has come out of this pandemic, is that we've been able to incorporate telemedicine, which was kind of on our distant future dream goals. And then it just suddenly happened. It was really funny because we had a plan to get our dietitian trying some telemedicine, and we had worked it out for a long time and worked with, all the people for the technology, and we had a go live date just for her. And then we were going to see how that went, and then maybe try, doing more than that later. And what's funny is then with COVID, all of a sudden we were 100%, all of us were telemedicine, well before her go live date was even scheduled to happen. So we got really forced into doing that a lot faster. So that's one of the things we are doing. We have group visits that we're doing. And I know Endocrine is trying to do some group visits too, and try to provide patients with that support to help them, with successful weight loss, while also helping them learn from other people's problem solving that goes on during the group. They can kind of see someone else get counseled and then kind of take some of those take home points. They get to learn from everyone, not just themselves. They get a lot more time with their healthcare provider in that group setting. So we had done a couple of those, and we were starting to kind of feel a little bit more confident with how to do them. And then when COVID hit, we had to cancel all those too, but then we've pivoted those to virtual as well. And now we've done 2 virtual group visits. So we're figuring those out too. So those are some of the things that we're doing in our clinic, and just trying to work as a team. So, when you come to our clinic, you're going to have interaction with us. You're going with one of the MDs, you're going to have interaction with the dietitian, you're going to have interaction with our nurse coordinator, and interaction with our APP, and we have some other groups we work closely with, like psychology and bariatric surgery and endocrinology. And so kind of putting all of the resources together to really provide patients with the support they need to manage obesity. So that's kind of what we do. And I don't know, is there anything else you wanted me to talk about?
That was all excellent. Thank you. Shri, I don't know if you maybe had some comments or thoughts on all of that in the metabolic group as well.
Yes, we have started group medical visits. We've had our first one. Unfortunately, it only had 2 patients in it. Like we do have an older population, and sometimes telemedicine is hard for them. So we are going to keep trying and keep seeing if we can make it beneficial. I thought it sounded great because I could give one spiel instead of 15 times to 15 people.
Would your first group visit was virtual?
Yes.
Yeah. I think the virtual actually has a lot of advantages, but it does take some getting used to. For example, what platform are you using to do them?
Video Connect.
Yeah. So we ended up switching to Zoom, and I don't know, the Video Connect we just had trouble using. But when we switched to Zoom, there's a lot of features in Zoom that I don't think Video Connect offers. And I know that eventually, if regulations tighten up, we may not be able to keep using Zoom. But for now, I think we're allowed to do that, and it has so many advantages. It's really easy for the patients. They usually already know how to use it, a lot of them. And we've been taking advantage of the polling feature, the raising the hand, the chat function, the emotions, changing their name and things, just to kind of get really a lot of interaction going on in the group. And that using those tools has really helped us. I'm not sure Video Connect offers all that, but maybe they do. We just didn't play around with it enough.
I have attempted to play around with it just so, I needed to see it from the provider side and I needed to see it from the patient side to help them troubleshoot, when they call. So it doesn't offer as much. I think I have 4 or 5 different of these video apps on my phone, talking with drug reps throughout the pandemic, also Doximity. I think, you can kind of like hide your phone number, things like that. But I do think we needed something more. I guess my expectations were higher of Video Connect than it was. I thought I could do a lot more on there, and it didn't live up to it. So I would hope to switch to a different platform.
Yeah, you may want to try Zoom. Ours went really well last night. Like I said, this is only our second one virtually, but we had, I think, 7 or 8 participants. And when you have that many, the really challenging part is making sure that you have enough time to get to everyone before it's gone on way too long. But we tried to make it fun. I think adding an element of fun is another really cool thing you can do with group visits. So, and I don't know if anyone else thought it was fun. I thought it was fun. We started out by having everyone rename themselves to their name and their favorite color, and then we could kind of refer to them throughout as like their name and their favorite color. We had everyone start out by saying, when they gave their introduction, we had them say how many hours of sleep they had gotten. And then the person who had gotten the most sleep got to go first when we did our individuals. So we kind of made it like a fun game that way too, because we know there's a big connection with sleep and weight. And it just gave them a chance everyone had a chance to say something and get used to sharing a little bit at the beginning. And we found like that was a really useful thing. But these virtual groups are all a big learning curve for all of us. And I think as we go on, we'll all probably figure out a little bit more about what works and what doesn't work.
I would really like to see a group of, our younger population, insulin pumps, to share tips and tricks on, what works for you versus what's not working. I mean, there are all kinds of things people have tried out there that, we hear about, and I think, gosh, I've never even thought about that. So I would like to see it go towards that a little more. Also, like college students, I know we started a support group for diabetes through kind of the Girls with Diabetes Education Center, and I think that's been really beneficial. But we are kind of getting a little bit of a hiccup on patients wanting to do group visits. I don't know if it's dedicating the time or feeling, that doctor visits should be private. I'm a pretty open person, so that I don't understand.
Mm-hmm.
So I just feel we have a little bit of a hiccup there.
Yeah, people have expressed a good amount of interest even from the beginning until it comes time to actually scheduling. And the in-person visits, we had more trouble. It seems like with the virtual, we've only done the 2, but it seems like as soon as we advertised it, and then they started like expressing interest. And I think because it's virtual, it allowed us, first of all, to pull from a larger, group of people who might not live around here. And I think that was helpful compared to having it be in person. But the other thing we did was we advertised what a certain theme was going to be for the talk. And I feel like that theme might have really piqued people's interest, because as soon as that message went out that our theme for this week was going to be cravings, boom, we had a wait list of people who wanted to get in.
Okay.
So that might be something that kind of piques people's interest, is just having a kind of a topic. Now, since yours are all going to be diabetes related, maybe that's not going to be as easy, because today's theme is diabetes. Guess what next week's theme is? Diabetes. But maybe you can talk about a certain aspect of diabetes each time to somehow, pique their interest. I think fun names, titles might also help. I don't know. I think get creative.
Thank you for your suggestions.
Sure. We're all figuring it out.
I had one kind of question to Donna and the others that are participating. So these are kind of 2 different groups. You have the endocrine kind of echo group talking more about diabetes management and things like that. And then Dr. Davidson's group, would you feel the, interest in hearing more of some from the metabolic, medicine side as well here in these sessions, or just wanted to kind of gauge people's interest, because we have been meeting with Dr. Davidson and Dr. Haggerty and some others about these topics. And so we're just kind of trying to see, do we want to keep them kind of their own things, or do we want to try to meld them, that kind of stuff?
I think it's very helpful. No matter, every time I've listened to any of these, as I'm on here pretty often. Some of it is more things that I feel like I can manage, but it's always good to hear everything, because our team coordinates. So we have pharmacists, social workers, patient navigators, nurse navigators. They're all on our team. So we're kind of looking at whatever the patient needs. So hearing the insurance, of course, we all have to deal with the insurance. And it is always, I've heard about the insurance many times, and I appreciate whenever it's put into an easy handout, because I'll forget it. But if it's something like what she's done today, I think that's really a quick reminder of how it works, because it does change, and every year the Medicare regulations might change a little bit, or the income guidelines. But then having the doctors tell what they are looking for or whatever, that helps us to know how to steer our patients there. The other girls can chime in too. I'm kind of newer on this end of doing that. I used to do transitions post-discharge, and now I'm going to be more working with patients on a regular basis. That will be my caseload, where I didn't have that before. And the other girls are more experienced with that part. So for me, I'm learning a lot, trying to take it all in, but some of them may be able, either Amy or Andrea may be able to add some to that too. But I always feel like I get some. Now, I will admit, now today I felt like this was pretty good. Some of the stuff I listen to is a little over my head, but I listen. And after I've listened to some of the conversation 4 or 5 times, I'm starting to get it. The hepatitis C one I watch, and that one's a little over my head. But I know more about it than I used to. So.
Thank you, Donna. That's great feedback. So we get that a lot too, is like the both sides are very useful, as a whole. So I think Amy might be on the phone, and I know Andrea should chat it in. A refresher is always appreciated with the information continually changing. That's for sure. So yeah, I think she's on the same boat as you, Donna. It's always nice having a refresher and all of that. So.
I'd like to add that this was really helpful for me, because we have struggled with the insurance so much, and it sounds like, in Endocrine, they've got some tricks that they've kind of worked out, and it's so good to hear that. So this is like a group visit for us as providers too, to get to kind of share things. So that was super helpful, and I really want my nurse to learn some of these tricks for helping us get some of these things approved, because we've not had as much luck.
And please, I know Andrea reaches out to me, Amber reaches out, I've even heard from Amy, so please don't hesitate to send me emails or in-basket messages. You can even attach your patient. I'll search through their chart, see if there's anything I can do. I've talked to neurology, I've talked to family medicine, MGP, I kind of would like to be a resource to keep us all, because, I do get updates, when I figure out something about Humana, that maybe it's an aha moment. I forget who needs to know. So if you ever come across it, feel free. I may have that knowledge stored up there somewhere.
I was just going to say too, it's really helpful for me to have those tools, because if we have things that are easy to explain to the patient, or easier, it's not always, even if you have an easy tool, it's a very complex issue when you talk about the insurance. And I feel like I navigate insurance all the time, but it's still, when it comes to my personal family, I have to think, now, is that out of pocket? Is that copay? What is, and then my husband has Medicare, and he's covered with me from the hospital. So, that's very complex, but having some tools that I can give some answers to, confidently. And then I can say, let me do some more checking, but I appreciate how simple you laid that out, because I feel like that is going to be something I can put my hands on, and at least try to start helping the patient understand why something isn't or is covered, or where else we can look for resources. I really appreciate it.
And I did Google when I first was asked insurance. I thought, what in the world am I going to, say? But my doctors do come in, like I said, they should be in here listening, because I give them this spiel every day, multiple times a day. But I went out and researched, and there was one page that brought up, an HMO versus a PPO. I read it. I still can't tell you the difference, but there was probably 60 different items I could click on about insurances, because they are all so different. So slowly learning, has to be an insurance specialist out there, but as for now, I guess I'm it.
When I years ago, I worked in Greene County Memorial Hospital emergency room, and I worked night shift, and that was when we started having HMOs. I had to call every night. It didn't matter if I called that insurance company the night before. It had changed by the next day. Every night I had to call them to try to get a patient's services admitted or transferred. It never stayed the same, even in a 24-hour period. So it was very eye-opening, to say the least.
Absolutely. It's always, the regulations are always changing. So a refresher on it was wonderful, Cherie. Thank you. Are there any other thoughts, comments, questions related to metabolic health as well? Didactic. It sounds like some sort of cross collaboration between the Endocrine, Echo, and Metabolic Group would be great. All right, guys. Well, I don't want to hold you any longer than necessary. If anyone does have any further thoughts or questions about anything we talked about today, please feel free to reach out to me. If you guys would like an invitation to join the metabolic group, anything like that, just reach out and I can send that over as well. So just a couple housekeeping announcements before we part ways. So our next session will be on August 26th, and Cherie is actually presenting on diabetes education and best practices. So definitely keep an eye out for that reminder. That's going to be a great session as well. And we will see you all next time. Thank you so much, everyone.
Thank you.
Bye. Thank you.